Good day, and welcome to Epstein, Becker, Green, and EBG Advisors webinar, Out-of-Network Billing, the Impact of Consumer Protection Measures on Health Plans and Providers. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have 5 fantastic speakers today. Robert Atlas, the President and Strategic Advisor of EBG Advisors in Washington, D.C., is serving as today's moderator. Robert is joined by Helaine Fingold, Senior Counsel in the Healthcare and Life Sciences Practice in the Baltimore office of Epstein, Becker, Green, Jackie Selby, member of the firm in the Healthcare and Life Sciences Practice in Epstein, Becker, Green's New York office, Basil H, Associate in the Healthcare and Life Sciences Practice in the New York office of Epstein, Becker, Green, and Lesley Yeung, Associate in the Healthcare and Life Sciences Practice in the firm's Washington, D.C. office. At this time, I'd like to turn the webinar over to Robert Atlas.
Good afternoon. Hello, everyone. As we now routinely see in the media, the maneuvering between health plans and healthcare providers impacts consumers and their wallets. Health plans feel the need to constrain the prices they pay and to tighten their provider networks. Providers want adequate compensation, and they may refuse to participate on the insurer's stated terms. Patients often get squeezed as a result. This is most evident when a single episode of care involves multiple providers who are part of the same care team but who don't all belong to the health plan's network. The most visible impact on consumers arises in emergency situations when patients are helpless to choose their caregivers once they enter the hospital emergency department. But sometimes, even when care is elective and can be planned in advance, patients still don't know all the caregivers who may be involved to make sure they're all in network. These situations often give rise to surprise bills, including bills for balances above the amounts that insurers will pay. In this next hour, my colleagues from Epstein, Becker, Green, and EBG Advisors, Helaine, Jackie, Basil, and Lesley, will explain how the federal government and the states are addressing this challenge. We have a lot of ground to cover, so I'll quickly hand the microphone to Helaine Fingold. Before I do, though, let me reiterate that you can submit questions using the Q&A feature showing on your screen. We hope to get to as many of these questions as we can during the hour. If we can't, we'll do our best to follow up after today. Helaine?
Thank you so much, Bob. So I'm going to start by, and you can go to the next one, Whitney. As you see, I took just a few selections that are evidence of what Bob said, that the news has been lots of stories around what some of the states are doing to look at these surprise charges, concerns from consumer groups and individuals who didn't fully understand the circumstances around their treatment and their medical bills and where they arose from. So that has clearly had an impact on the states and the efforts that the states are making, as well as the federal government. Go to the next one, Whitney. So as Bob said, surprise bills can arise in one of 2 ways. One is really relating to the emergency room, where at an in-network hospital, or it could be at an out-of-network hospital, but obviously at an out-of-network hospital, people would know that the bills are going to be out-of-network. The issue is when you're in an in-network hospital and you get treated by providers who are not necessarily part of the plan. They don't, while the hospital participates, the provider, not all the providers do. Or where there is a scheduled treatment, surgery or other care at an in-network facility, which may also involve providers who are not in-network with the enrollee's health plan. Most of the actions that states and the feds have taken around this tend to be with the emergency care rather than the scheduled treatments and the issues raised there. But we will walk through what we've been seeing. I will point out, and that's the next slide, Whitney, most recently, and very recently, in fact, the NAIC has been working on a revised Network Adequacy Model Act. They have finalized, though it's, they've finished voting, finished working on it. They're going to finalize it by vote November 22nd. And there are several provisions that were added to the previous version of the Model Act that address these surprise bills. There are notice requirements that are imposed on in-network facilities with non-participating facility-based providers, saying that they have to provide written notice within 10 days of scheduling a treatment or at the time of pre-certification and admission, that the services may be furnished, or some aspect of the services may be furnished by out-of-network providers. And for, if there was an emergency service, then the bills that are sent have to include a notice, the payment responsibility notice, stating that the patient is only responsible for the in-network cost-sharing amount. Also, where there are balance bills, so where there are providers that are out-of-network that are balance billing, they have to include a specific phrasing, the payment responsibility notice phrasing that is in the Model Act. There's also a notice requirement on carriers that does overlap with the notice requirement on the facilities. Also, at pre-certification has to state to the covered individuals that some of the services may be provided by out-of-network providers. And finally, there's a process, a mediation process that carriers must establish for providers who object to rates set by the carrier's out-of-network provider billing process. Now, granted, the NAIC, you realize, it's a model act. The states don't have to adopt it wholesale, and there is, as you read through, and there's notations, interpretive guidance within the text of the Model Act, that the states will obviously adapt the language. So if the state wants to allow balance billing or not allow balance billing, it would adapt what it includes from the Model Act. So these are not mandatory. It's just this is what the NAIC included, and the states themselves will decide what aspects of the Model Act to incorporate. So what I'm going to give as a high-level discussion is what has happened on the federal level for out-of-network services. Whitney, you can go to the next one.
If I may just interrupt, somebody's asked a basic question of what is balance billing, and I'll just say that's when the provider bills, the provider's charge is in excess of the health plan's allowable charge, and they seek the additional amount from the patient.
Thank you, Bob.
Sorry.
Sure. So federal protections for out-of-network services were enacted through the Affordable Care Act. The ACA did impose these requirements, and they essentially apply to emergency services. And if the plan or the health insurance coverage includes emergency services, coverage for emergency services in a hospital, then emergency services have to be covered for both in and out-of-network providers. And the administrative requirements or any limitations imposed can be, for the out-of-network, can be no more restrictive than that as applied to the in-network. So you can't treat them more stringently or put more significant requirements on the out-of-network access. They have to use cost-sharing requirements that do not exceed those that would apply if the services were received from an in-network provider, and the reimbursement of the out-of-network emergency services have to be at a reasonable, quote, reasonable level of reimbursement. These requirements do apply across the health insurance market. These were part of the market reforms. They apply to group health plans and group and individual health insurance coverage, including the large group and self-insured, as well as the individual and small group market plans that are both on and off of the exchanges. Next one, Whitney. I think, oh, you're there. Okay. So the federal protections allow, they don't prohibit balance billing, as we just discussed, as long as it's allowed under the state law, right? So the state law is still going to govern whether a provider, an out-of-network provider, can balance bill. And where there's balance billing allowed, though, the regulations for these provisions, so CMS and the Department of Labor and the IRS rules say that the plan must provide a reasonable level of reimbursement, which is defined as the greatest of 3 amounts. Those amounts are the amount negotiated with the in-network providers for emergency services furnished, the amount calculated using the same method the plan usually uses to determine payments for other out-of-network services, so that might be the usual customary and reasonable amount, or the amount that would be paid under Medicare for the emergency service. And the reasonable level of reimbursement requirement and the definition of the greatest of 3 is to protect enrollees from excessive balance billing amounts. So where the plan pays a reasonable amount, the theory is, then the burden, the balance billing burden is not going to be as great on the enrollee. The minimum payment protection doesn't apply, so this greatest of 3 reasonable level of reimbursement doesn't apply where states prohibit balance billing, or the plan itself is responsible for paying the balance billed amounts. Again, the point of the reasonable level of reimbursement is to protect the enrollee. Where there's no ability to do balance billing, then CMS has said that, that this minimum level of reimbursement is not apply. And plans have to provide their enrollees with adequate and prominent notice of their lack of financial responsibility with respect to balance billed amounts, where that's the case. So I want to note in the next slide that while the ACA rules do have a maximum out-of-pocket limit, out-of-network costs don't apply to the maximum out-of-pocket limits. So that's, you know, not only do you have the balance billing issue, that doesn't accrue to an individual's MOOP, maximum out-of-pocket, and so that they can't, it doesn't help them reach the point where the plan is going to cover above and beyond. So plans are not required. I will say plans can count cost sharing for out-of-network or balance bill amounts towards the maximum out-of-pocket. It's just not required to be done. And I'll also note that if a plan does not have a network, so for example, a plan may not have an in-network emergency services, CMS has said that all emergency service providers would be considered in-network for purposes of applying the maximum out-of-pocket limits. So any cost sharing that is paid where there's no emergency services network, any cost sharing paid for emergency services would accrue to the maximum out-of-pocket limits. I'm going to turn this over to Lesley Yeung, who's going to talk about just an overview of where the states are on this legislation and talk through some specific examples.
Thanks, Helaine. So the next few slides illustrate some of the research that we've put together, we've pulled together, that shows which states have different types of out-of-network protections in place. I'm not going to speak to each of these because there's a lot of detail here, but just generally, there's 3 categories of protections that we've looked at and we'll be discussing in more detail today. May help put sort of just a parameter around our discussions is that, as you can see on slide 15, the first category in which states require out-of-network services to be treated as in-network services. So on slides 15 and 16, we talk about mandates for coverage for emergency services at out-of-network facilities. And then on slide 16, which states mandate coverage of out-of-network services provided at in-network facilities. We also go into a little bit further detail about that on later slides as well, talking about restrictions on balance billing for out-of-network emergency services. That's the first category. The second category that we'll be discussing in more detail today is illustrated on slide 17, That shows which states require alternative dispute resolution related to billing for out-of-network services. And then the third category that we want to touch on today is illustrated on slide 18, and that focuses on which states have out-of-network disclosure requirements. So I'm now going to do a deeper dive on a few of the states that have these different types of out-of-network protections in place, and then Jackie and Basil are going to speak in even more detail about the new law that was enacted in New York, because that's the most expansive law that touches all of these different areas. So if we could turn now to slide 21, Texas is the first example that we want to go through today. And there's some general takeaways on this slide 21 here that I'll speak to sort of as we go through the slides quickly. Again, I'm not going to speak to everything on each of the slides, but we will provide these slides to you so that you have the background information. Some of these laws are complex, so we don't want to speak to everything, but I'm happy to answer follow-up questions as well. So on slide 22, the first category that we talk about is that Texas requires that HMOs and EPOs, or exclusive provider organizations, pay a negotiated or usual and customary rate for emergency services performed by out-of-network providers. So Texas does have restrictions on, or requirements that out-of-network emergency services be treated, be paid for in a certain way. Texas did attempt to enact legislation earlier this year, and that legislation would eliminate balance billing for out-of-network emergency services. That legislation wasn't actually enacted, and therefore balance billing is still allowed on these types of services. If we move to slide 23, actually on slides 23 and 24, we talk about the disclosure requirements that both health plans and physicians have to follow. And these disclosure requirements relate to pricing and network participation, so that members in the plans clearly know, are able to identify, which facilities and which providers are in their network, and what they might be responsible for paying. Moving on to slide 25, Texas does have a mandatory dispute resolution system for preferred provider benefit plans and health benefit plans other than HMOs. And this requirement was actually recently expanded to allow plan enrollees to seek mediation when they receive a surprise bill of over $500. Previously, the law stated that the alternative dispute or the mediation process was available to people who had bills over $1,000 or more. So this is making it more accessible to people who are facing surprise bills in Texas. Moving on to slide 26, we're going to talk about Illinois. Again, we provide sort of an overview of what's going on in Illinois related to coverage of out-of-network emergency services and other services that meet a good faith and network adequacy test. So if we want to switch to slide 27, I'll go into a little more detail about that good faith requirement. So Illinois mandates coverage for out-of-network emergency services at the same level as if they had been provided by a preferred provider, so they must be covered like they were in network services. Also, when a plan enrollee has made a good faith effort to use the services of a contracted provider but has not been able to access such a provider, then the plan must pay for those services at in-network rates. And so that's the good faith test that, the plan networks have to be adequate. So if there's no providers available, then the plan needs to pay for those services provided out of network as if they had been in network. And with all of that, the enrollee is held harmless from balance billing in Illinois. On slide 28, we go through the disclosure requirements. Illinois has disclosure requirements between the health plan and the out-of-network providers, and this requirement is really related to the proposed reimbursement and applicable cost sharing that the provider can actually collect from a beneficiary. And the requirement talks about whether the beneficiary basically agrees to assign their benefits to the out-of-network provider or not, and that assignment impacts whether the out-of-network facility can bill the patient directly or not. Moving on to slide 29, Illinois has established an arbitration process between out-of-network facility-based providers and insurers or health plans. There is a specific process laid out for initiating arbitration when a payment dispute has not been resolved, and that sort of commences if the dispute hasn't been resolved within 30 days of the receipt of the explanation of benefits from the insurer or health plan, then the provider can, or the plan can go through this process of requesting arbitration. So we're going to move on to Florida now, and that's on slide 30. As we will see, Florida is another state that has restrictions in place, but similar to Texas, has also tried to further expand those restrictions earlier this year, but that expansion was not enacted. On slide 31, we talk about the requirements that Florida has for HMOs. So these requirements apply to HMOs, that the HMO must pay for emergency services provided by out-of-network providers and prohibits providers from balance billing for those services. Florida also restricts providers from balance billing for ancillary services provided to a patient at an in-network hospital if admitted by an in-network physician. So those are services that would have been authorized by the HMO. On slide 32, we talk about, this slide provides an overview of the proposals included in the state legislation earlier this year that I mentioned that would have further expanded coverage for emergency services provided out of network. This bill wasn't enacted, but as you can see, a lot of states are thinking about these issues and trying to see how they can put further restrictions around surprise bills and out-of-network coverage. On slide 33, this shows that Florida, similar to what Helaine had talked about on the federal side, that Florida has actually put into its requirements how plans should pay providers when the service is provided out of network. And so it lays out that the HMO must pay either the provider's bill charge, the usual and customary charge, or a charge mutually agreed to by the HMO and the provider. And then for non-emergency services, so that was the formula for emergency services, and for non-emergency services, HMOs can negotiate with out-of-network providers on rates. Switching to slide 34, Florida has disclosure requirements for insurers to inform policyholders about things such as who are their exclusive providers in the network, what coverage and billing policies exist, and does the policyholder, there is a requirement that the policyholder must acknowledge that they received this information in writing so that the information has been conveyed to them and they're aware of it. On slide 35, Florida, unlike some of the other states we've seen, actually has an optional dispute resolution process that providers and managed care organizations can participate in. If the parties do participate in the process, then the review organization that administers the process, and you'll see that's Maximus, who has the contract with Florida, whatever determination that they make is actually binding on both parties, and the losing party must pay for the cost of the review. And again, that's an optional process. All right, the last state that I'm going to go through before turning it over for a more in-depth dive on New York is California. California has specific requirements for HMOs and some PPOs, and these are the plans that fall under the jurisdiction of the Department of Managed Health Care. So if we switch to slide 37, you'll see we describe that this page talks about the balanced billing prohibitions on emergency services. And so HMOs and PPOs must pay for the reasonable and customary value of out-of-network emergency services, and balanced billing is prohibited. The balanced billing provision was actually challenged in court by providers and upheld by the California Supreme Court back in 2009. And the court stated that emergency room physicians under this provision may not bill service plan members directly for amounts that the plan did not pay for the emergency room treatment that the member received. So switching to slide 38, similar to what we saw in Illinois, when there are insufficient in-network care providers, and health insurers are required to provide out-of-network care at in-network prices. The regulations that create this requirement, and the previous version had expired on October 27th, but that's actually been further extended to January 26, 2016. And so these are regulations that sort of just keep getting reenacted and pushed further along by the state. On slide 39, this talks about the bill that California tried to introduce or tried to enact in February of this year. And this bill would restrict balanced billing and would actually implement an independent dispute resolution process for out-of-network providers. Again, this bill hasn't been further considered by the state yet. It hasn't been enacted, but could be reconsidered in a later state legislation. On slide 40, this is a discussion of the payment requirements for out-of-network providers. And again, California has laid out specific, this is probably one of the most specific of what a plan has to take into consideration when paying out-of-network providers. And there's a whole list of different sort of criteria that the plan must take into consideration when determining payment, and that includes training and qualifications, length of time in practice for the provider, the nature of the services provided, the fees usually charged by the provider, prevailing provider rates in the geographical area, and then other aspects that might be relevant to the provider's practice, as well as unusual circumstances. So pretty broad parameters put around those payment requirements. And then for non-emergency services, there are additional billing restrictions on to how those payments should be made based on an enrollee's evidence of coverage. On slide 41, we talk about the disclosure requirements that are in place. In California, there's disclosure requirements for network facilities to the insured about out-of-network providers who are likely to be involved in providing non-emergency care, as well as the estimated cost of what those services are likely to be. And that language is also included in the emergency regulations that I mentioned before that keep getting extended. And then finally on slide 42, California does have an independent dispute resolution process in place to resolve claim disputes. This is a voluntary, non-binding dispute resolution process to resolve claims, and providers and payers are encouraged to comply with the decisions of it's called the IDRE, external reviewer, but is not required to. So that was sort of a very quick run-through of all of a couple of the states that have sort of the most expansive amount of restrictions in place as of now, as well as, these are states that are also looking to expand them further. But now I'm going to turn it over to Jackie and Basil to talk about New York, who has implemented a new law this year.
Thank you, Lesley. Hi, this is Jackie Selby, and I will cover a new law in New York that arguably provides more significant consumer protections than most states and the federal law. The law was adopted effective March 31 of this year. First, I will cover new disclosure requirements for providers and plans. And second, I'll address what a surprise bill is, how it's defined. And given that this is a national audience, I just want to mention that the New York law does apply to services provided outside of New York in some cases. I'll explain that in a little more detail further on. And then third, I'll cover new protections for emergency services as opposed to surprise bills. And then Basil will address the new dispute resolution process that's in place for out-of-network services. So next slide, please. First, the new disclosure requirements. I'll just point out the highlights since they've been in place most of the year and most providers are probably compliant by now. So professionals need to, in writing or on their website, list the names of the plans in which they participate, the names of hospitals with which they're affiliated, that the amount or estimated amount for a service is available upon request, and if they get such a request, the amount or estimated amount that will be billed. Next slide, please. Besides the requirements I just mentioned, physicians have a few additional disclosure requirements. The first bullet is in, sub-bullet is in an office setting or for services that are based on a referral, and the second bullet is in the hospital setting. So for services provided in an office setting or for referred services, physicians must disclose the name, address, phone number of providers scheduled to perform certain services like anesthesiology, lab, pathology, radiology in their office, or if it's referred by the physician. So if they send lab work outside the office, for example, they need to disclose the name, address, and phone number of that lab. And in the hospital setting, they need to tell both patients and the hospital the name, address, phone number of other physicians whose services were arranged by that physician, and information how to determine the plans in which those other physicians participate. Next slide, please. Hospitals must post on their website, so this is hospitals instead of professionals. Hospitals must post on their website a list of their standard charges, the plans with which the hospital participates, a notice that physician services provided in the hospital may not be included in the hospital's charges, that physicians who provide services in the hospital may or may not be in the same plans as the hospital, and that the patient should check with the physician arranging for his or her hospital service to determine which plans that physician participates in. Next slide. Also on the hospital's website must be the names, address, phone numbers of the groups that the hospital is contracted with, including radiology, anesthesiology, pathology, and information on how to determine the plans in which they participate. And finally, the website must list the names of physicians who are employed or contracted with by the hospital. The hospital can provide a central contact number if they want so that the patient can get more information about those physicians, but they don't have to. Next slide, please. Besides on a hospital's website, information also needs to be put into registration or admission materials in advance of scheduled, i.e. non-emergent services. I won't go through these bullets in the interest of time, but you can read them. You'll get a copy. Next slide. There are, besides providers, there are new disclosure requirements as well for health plans. One of the biggest changes involves provider directories. They need to be on websites, but there are also new tighter time frames around changes. So plans must update their website within 15 days now for any addition or termination of a provider from its network or from a change in a physician's hospital affiliation. Plans should include language in their downstream provider contracts so that physicians report their hospital affiliations in accordance with those contracts. Next slide. Also regarding payment, plans must disclose the amount that they will reimburse under their out-of-network methodology to be set forth as a percentage of UCR, and as well as actual examples of anticipated out-of-pocket costs for frequently billed out-of-network services. Next slide, Whitney. And plans must also disclose information that permits an insured to determine his or her out-of-pocket costs for specific out-of-network services. A plan can satisfy this requirement by linking to an independent source, the website of an independent source like Fair Health. If Fair Health is not used by the health plan, they want to use another independent source, they would need approval from the Department of Financial Services. Next slide. Plans must also, upon request, provide the approximate dollar amount that they'll pay for an out-of-network service. This can be a range of dollar amounts, and they should also include a disclaimer that that dollar amount or range of dollar amounts could change based on the actual services that were provided and the codes that were submitted for those services. Next slide. In addition to disclosure requirements, there are new network adequacy requirements for plans. Now all health insurance plans in New York that issue policies that use networks, provider networks, are required to obtain network adequacy certification. Until this law, only HMO products were required to do that, and the requirement now expands to other products, including PPOs and EPOs. And the networks in all of the plans must be approved by the Department of Financial Services at the time the policy is approved, in at least 3 years, every 3 years after that, or if there's an application to expand the service area. And the standards used to determine network adequacy are the same ones that apply to HMOs. Next slide, please. This describes those network adequacy requirements. I'm not going to go through, I'm sorry, I'm on slide 55. Let me. Next slide, please. Maybe it's just our screen. It's not showing 55, but I'll just continue. I'm not going to go through all the specific network adequacy requirements, but I would just want to point out that they don't really get into tiered or narrow networks and adequacy at each tier. Those are addressed in the latest NAIC Model Act guidance that Helaine went over. Okay, we're on 55. Next slide, we'll go to 56. And another new obligation related to network adequacy is that if a plan covers out-of-network care, it must provide at least one option for coverage at least 80% of usual and customary costs for each out-of-network health care service. That's a new requirement under the law as well. Next slide, please. Now we'll look at new protections around surprise bills, what New York calls surprise bills. And how does New York define what a surprise bill is? I think it's broader than what are traditionally viewed as surprise bills. It is, first of all, used only for non-emergent services. There's another part of the law that addresses emergency services. And this grid is an attempt to summarize kind of the three categories of surprise bills. So the first row is the classic kind of surprise bill, and most similar to other state laws where a non-PAR physician provides services to an insured patient at an in-network hospital or AMSURG center. And the second type, the next row, is a bit more unusual, I think. It's if a service is provided by a non-PAR provider, not just a physician, to an insured patient anywhere, and that means not just in a hospital or AMSURG center setting, but it can also be outside of New York. If the patient was referred to that non-PAR provider by a PAR physician, so a PAR physician referring to a non-PAR provider, without the patient's explicit written consent, that referrals to a non-PAR provider and may result in costs that aren't covered by the plan. So kind of the classic example, I think, of this type of surprise bill would be lab services. If a physician's referred to a lab or their specimen is sent to a lab that is non-PAR or not in their plan without their explicit written consent, a bill from that lab would probably constitute a surprise bill and subject to the protections under the law. And the third category of surprise bills, the last row, is a physician, similar to the first row actually, but it's for uninsured patients at a hospital or AMSURG center, and only if the patient hasn't received timely received all the disclosures that are required that we just went over. So this category goes further than other out-of-network laws, if you will, in the NAIC Model Act, since there's no real network involved since you're an uninsured patient. All right, next slide, please. This is actually the same definition, just in prose instead of the grid, so we can skip this slide. So now we'll take a bit of a closer look at the second type of the surprise bill for those referred services. And if you are a provider that is not participating in a patient's plan and you receive a referral, it's only bills for services that are described in the orange part of the circle that could constitute surprise bills and be subject to the law. And those are services that are provided to an insured patient and you are not participating in the plan and there was no explicit written consent obtained from the patient. Next slide. Now there are a couple of slides that go into more detail around these referrals and include examples of referrals that would be and would not be surprise bills, but in the interest of time, I think I'll skip these two slides and we'll go to 62. So here are some ways for providers that receive referrals to obtain explicit written consent in order to avoid a bill constituting a surprise bill. I'm not going to go through these in any detail since we want to cover a bit more territory on New York. So let's go to the next slide. There are, the new law also has new billing requirements related to surprise bills. So surprise bills that are sent to a patient by a physician, not all providers have to do this, but physicians have to now include an assignment of benefits form as well as a claim form. And if the patient signs and returns the assignment of benefits form, then the out-of-network provider can negotiate with the plan if they don't get their billed amount. But at the end of the day, the plan must pay a reasonable amount. If the out-of-network provider doesn't like that amount, they can dispute the amount with this new dispute resolution process that Basil will address shortly. But the out-of-network provider can only bill the patient per the EOB. This prohibits balance billing, in other words. They can only bill the member cost share. Okay, next slide. If the patient doesn't sign and return the AOB, the plan can process it in their usual way. The provider can bill the patient, but the patient may dispute before they have to pay the bill, and the dispute resolution entity can decide the reasonable fee. Next slide. Besides surprise bills, the new law strengthens protections for emergency services. Again, surprise bills don't include emergency services. So there are new rules for emergency services provided by a physician to an insured if the physician's not in that insured's plan, or to an uninsured patient. And many emergency services with bills less than approximately $600 are excluded. There's an annual inflator for that amount. And if an out-of-network physician bills an insured patient's plan, then the plan must hold the patient harmless and pay the amount pursuant to the Affordable Care Act. So the federal law applies here. But the provider now can dispute the amount that was paid by the plan, and the dispute resolution entity selects between the plan's payment and the physician's billed amount. If the out-of-network physician bills an uninsured patient, the patient may file a dispute. I think they need DFS, Department of Financial Services agreement, though, before they file that dispute, or DFS can decide not to take that dispute. All right, next slide. Finally, I just want to mention that there are limits in the law as far as its scope. Excuse me, some products are exempt. Under the surprise bill provisions, exempt products include Medicare, managed long-term care, Medicaid fee-for-service, workers' comp, and no fault. I'm sorry, we're on the next slide, Whitney. Slide 66.
We're on slide 66. You may not be able to see it.
No, we don't. Sorry about that. I don't know. We have a glitch on our end. But so surprise bill provisions, I said, exclude the Medicare, managed long-term care, Medicaid fee-for-service, workers' comp, and no fault. Emergency services, same as above, plus Medicaid managed care. And self-funded plans, since they're not subject to the law because they're not governed by HMO or insurance laws, they're not subject to the law, but note that the protections that are provided to the uninsured population under this law would apply to patients that have, or members that have self-funded plans. I will turn it over to Basil Kim to cover the dispute resolution process. Thanks.
Great, thank you, Jackie. So just to close out our presentation today, I wanted to give a little more detail around the independent dispute resolution process that's governed by what we're calling IDREs in New York State, or independent dispute resolution entities. This process and these entities have been adopted under New York State statutes to go and bolster the surprise bill new regulations from earlier this year. And as you'll see in slide 67, plans, physicians, and providers and patients have the right to request a review by an IDRE to resolve disputes. This is actually being done via something that the Department of Financial Services, New York's Insurance Department, has set up. They set up a portal on their website which allows the applications for these reviews to occur. And actually, since October, 80 applications or so have come into the state. What's interesting is that even though you apply, it doesn't mean that it'll be heard because the actual dispute needs to meet eligibility requirements. But we heard from the state that approximately 80 or so have come in since October. And note that different procedural flows exist based on the patient's status. So if the patient who's impacted is an insured with an AOB, there's one process. Insured without AOB is another, and then also for the uninsured. So not only are there different processes, but also different responsibilities as to who needs to pay for the cost of the IDRE. So if we go to the next slide, these are some examples of those different procedural flows that I mentioned. So for out-of-network physician services that include an AOB, the health plan must pay the physician the billed amount or attempt to negotiate a different amount. If such negotiation ends up failing for whatever reason, the plan must pay an amount that the plan determines is reasonable, and then either party can submit the dispute to the IDRE. Note, however, if the plan wants to submit the dispute, it must first pay pursuant to the sentence before. For out-of-network physician services provided to an insured where there is no AOB or to an uninsured patient, the IDRE, they can submit it and they do not actually need to pay the bill before the dispute is heard. If you look at the next slide, actually the state has set up an entity by which health plans and providers can actually seek some more information. So if they don't believe that a bill meets the definition of surprise bill, the health plan or the provider can contact Consumer Assistance Bureau, and that bureau will, taking a look at the information that was provided, help determine whether or not it's a surprise bill. Similarly, if the dispute has been submitted to an IDRE, a health plan, or a provider, the IDRE is sort of a work in progress in some way. So if there's additional information that any entity believes would be helpful to the IDRE in making their determination, then they can submit to the entity. The current IDREs in New York are IMEDICS, IPRO, and MCMC, but the state has advised us that these are considered actually temporary IDREs, and an RFP will be going out to entities that desire to become IDREs, and a formal process will be put in place to create permanent entities. If you go to the next slide, 70, the IDRE entity will make a binding decision within 30 days. And for out-of-network physician services that include an AOB, they'll select either the plan's payment or the physician's fee. If it's an out-of-network physician services provided to an insured that does not include an AOB, the IDRE will determine what it calls a reasonable fee. Something interesting that I mentioned before is that the status of the patient also defines who's responsible for payment of the IDRE process. And that's not on the slide, but I wanted to provide some information. So if it's a dispute between a provider and a plan with an AOB, the provider would pay the cost for the IDRE if they determine that the health plan's payment is reasonable. Vice versa, the health plan pays for the cost of the IDRE if they determine that the provider's fee is reasonable. If there's a settlement, and I'll give a reason for that, but if there's a settlement between the provider and the plan, they'll share a prorated cost. And it's important to note that there may be a minimal fee to a provider or health plan submitting the dispute if the dispute is ultimately determined to be ineligible or incomplete. For disputes involving patients who are not insured or insured without an AOB, the doctor would pay the cost of the IDRE if the doctor's fee is considered not reasonable, or the patient would pay the cost of the IDRE if it's determined that the doctor's fee is reasonable, unless it poses a hardship on the patient, which New York State is defining as 250% of the federal poverty level or below. Just to give you a sense of who the IDRE is composed, who composes the IDRE, the reviewers are usually individuals with training and expertise in healthcare billing, reimbursement, UCR, and they'll also consult with licensed physicians who are in active practice in a same or similar specialty as the bill that's in dispute. And what the IDRE sort of considers when they're making a determination is whether there's a gross disparity between the fees charged, the provider's training, education, experience, circumstances and complexities of the case, patient characteristics, and other factors that they may consider to be relevant. And also note that when billing for out-of-network services, all physicians must provide patients with claim forms that the patients will use, as Jackie had mentioned before. Going to slide 71, New York is using something called the nexus test. So as Jackie mentioned, this expands beyond the borders of New York State, because if a participating provider sees a New York patient outside of New York without the patient's explicit written consent, sends it to a non-par provider, that would be considered a surprise bill. Also, if there is something called a sufficient nexus, so for instance, if an insured is covered under an HMO for delivery in New York and has blood drawn and that's sent out of the state, if that lab does work regularly with New York providers, that's considered within the nexus of New York State and would be covered by the New York law. The next slide just has some guidance links from the Department of Financial Services and DOH, and I will turn it over back to Helaine for some final thoughts.
Great. Thank you, Basil and Jackie and Lesley, very much for your discussions. So I think the message here that we want you all to take away is that these are measures are being put in place nationally by the states. This is clearly an issue that is concerning state legislatures, and although things are being done to varying degrees, there are concerns around out-of-network billing and disclosure on surprise bills. So these laws and the regulations are putting additional responsibility on the plans and providers to make sure that their enrollees understand the circumstances, help increase transparency generally in the healthcare marketplace. National standards are sort of being developed to help standardize some of these requirements, but the states themselves are sometimes going beyond where national is. So as you can hear from the discussions, the federal requirements, which they are out there and they apply to everybody, some of the states are going above and beyond. And we chose, I mean, New York is certainly an interesting case study, and the 4 specific states that Lesley discussed we wanted to highlight because these are some of the more kind of extreme or active endeavors that the states have taken, and those of you in other states should certainly be watching and understanding what the discussion is about when it comes in your state to be addressing, and certainly where, as Basil just referenced, if you're out of state but are providing services where there's a nexus to New York or depending on, again, the other state laws, you may be impacted by this. So this may affect you where even if you yourself are not in New York, if you have enrollees or patients that are using your services. So we don't have a lot of time for questions. Let me do a quick, I did have a question somebody asked about whether this applies to, the regulations apply to self-insured as well as fully insured. As for the state laws, they would not apply to self-insured. The federal requirements do apply to self-insured as well as fully insured.
Helaine,
state requirements would be preempted. Bob, you want to jump in?
I'll lead some Q&A here.
Sure.
Can you add, the 2 questioners asked if the federal law is proposed or set?
Federal law is already effective.
Okay. And there was somebody wanted to know specifically about lab services. How do they fit in to the, you know, if a lab is out of network, how does that work generally?
Yeah, Basil, do you want to, in New York, and Basil, if you want to jump in, you can do that. There's,
sure.
I think Basil just discussed. Go ahead.
Sure. I mean, labs are covered under this law, and they fit under the definition of provider. So as I had mentioned, labs are often one of the primary providers to whom that surprise bills would come to patients from. You'd have an in-network provider who's sending a lab out to an out-of-network lab, so this definitely impacts them.
Right, in other states it would depend on the state law as to how it's articulated, so go ahead, let's do another one.
One questioner said, for out-of-network providers, is the patient's assignment of benefits sufficient to give the provider appeal rights with payers? Can payers require additional authorizations for out-of-network providers to appeal denials?
Again, I think this is going to depend on the state and the specific state law as to what they define as, you know, who has the ability to appeal.
Okay. A couple questions came in about care related to what sort of EMTALA definition of emergency and definition of a true emergency. One is when referencing emergency care, is this EMTALA only or all services delivered in the ER? What if an inpatient admission follows? And I'll tack on a separate questioner's question. Is there a definition of true emergency? We don't want employees running to the ER for routine care such as cold and flu.
Yeah, on the federal side, the federal requirements go back to the definition of emergency under Medicare. So it's 1867E. They go back to reference that as the touchstone for emergency. And the NAIC proposed model law, that also has a definition of emergency. I believe it's the reasonable person, the knowledgeable, I forget what the terminology is, but it is a reasonable person standard as to whether something is an emergency.
Okay.
My expectation is, Go ahead.
Sorry, we're down to 1 minute left.
Okay.
And question is, where was I? Does New York law consider post-stabilization care following the ER services as emergency care?
Hi, it's Jackie. No, I think once the patient stabilized under EMTALA, that would be the end of the coverage under the emergency services section.
Okay. Well, I want to leave on time. I really appreciate everyone's participation. Based on the meter here, almost everybody stayed to the very end. So I guess it's a fairly compelling topic. And as we said, we will make the slides available. Watch for a notice on how you can get the slides. And if I know a couple dozen additional questions that we didn't get to were asked, and we will try to communicate directly with the questioners to answer those questions individually if we are able to. So thank you so much, everyone, for participating in today's call, and thanks to our presenters. And we hope you learned something useful. Bye-bye now.
Thank you for joining us. This concludes today's webinar. And approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.